2, go. All right, good morning, everybody. And we'll get rolling here. It's about 7:31 or so. This is our last fellow presenter of this section, and then we will switch back over to staff presentations. And I'll give a little update afterwards, but we'll get rolling. So we've got Dr. Charles Kenyon here. He's one of the Emory fellows, and he is giving a talk on a case of quad tendinosis / quad tear. And so with that, Charles, you go ahead and share your screen and take over.
Awesome. Thank you guys for coming this morning. Get the screen pulled up here. All right, and we should be rolling there. Thanks for everybody for joining. Again, I'm Charles Kenyon. I'm a PM&R background from University of Washington and currently at Emory doing my sports medicine fellowship. I'll be finishing up my first year of traditional fellowship this year, and then in a couple weeks we'll be transitioning into the chief fellow role here at Emory with a little bit more of a research focus and taking on some more administrative tasks. So I'll be doing a more of a unique 2-year track and fellowship, but some of y'all on the call know me as Charles Charlie, either is fine. But today we'll be talking about a case of quadriceps tendinopathy, and thanks for joining. All right, so the objectives and outline for the talk, obviously we're getting to the point where we have 50 plus of these lectures now, which is an incredible resource for everybody. So we'll follow the general same principles, just with the time of year being July. I've essentially a year of fellowship under my belt, and knowing that there are probably going to be a lot of incoming fellows who have either recently started or will be starting in a couple weeks, tuning in at some point. I'm going to try and gauge things more for those who are coming into fellowship, maybe with a little bit of ultrasound experience, and also recognizing that some people are coming in and learning an entirely new skill set. Quick thanks first to AMSSM, Fellows Committee, Online Education Committee, Ultrasound Committee, of course, Dr. Cruz and Dr. Hoffman, both these ultrasound lectures and the online fellows lectures, especially for me being a busy parent in fellowship, having this online resource and being able to go back and look at things more than once and really kind of customize my learning has just been a tremendous resource. And then also, there's way more names, obviously, than I can list, but just wanted to give shout outs to all mentors and people who've gone out of their way to help me with my own ultrasound education. With Daniel Clearfield during medical school at Texas College of Osteopathic Medicine, Eric Lotzka and Brian Liam over at University of Washington, who led our ultrasound curriculum over there. My program director, Ken Mountner, and Robbie Bowers, who has been guiding our ultrasound curriculum here at Emory over the year. Our beloved current chief fellow, William Berrigan, who's just been a tremendous friend and mentor, always gone his way to either be scanned or teach us as fellows. And it's just been really a great friendship having Bill around. And also Rosa and Stacy, my current co-fellows. It's just been an amazing experience being somewhere to learn and grow with all of us having a unique skill set and take that into ultrasound and fine tune our skills through the year. So like I said, if you're anything like me coming out of residency, you felt confident in some things, but maybe weren't quite sure where your ultrasound skills came in. And I just, that was me a year ago. And through the year, you're going to learn a lot. But it's good because Dr. Hall and Dr. Hoffman's on this authored paper as well, but we have this roadmap now. We have this updated curriculum for sports medicine fellows. So make sure that you guys check out this article. It's open access, read through it, know what your expectations are for the year, talk through expectations with your curriculum directors and program directors, and you'll be set up for success. Also, some of the terminology might be unfamiliar. There's a lot of known inconsistencies between different institutions, depending on where someone trained, where they're from. But also a big shout out to the author group who came out with this recent consensus statement in an effort to move forward and standardize ultrasound terminology. So get in good habits early in the year. Be sure to review both these documents and make sure you're kind of standardizing your language and approach as you move forward. Incoming fellows, you're about to embark on an amazing journey learning about anterior knee pain. It's going to be most likely one of the more common things that you'll see coming into clinic. So you're off to great places. Today is the day. Your mountain is waiting, so get on your way. And with that, there's going to be kind of two types of fellows who, when they hear a complaint of anterior knee pain or kind of anything through the years, going to be two types of people. One, there's going to be the Roy Kents who just face the onslaught of anterior knee pain throughout the year. And they're just kind of over it. Oh, it's just anterior knee pain. I'm going to go through my standard algorithm and kind of plug forward. This is kind of a bread and butter visit. And then there's going to be the Danny Rojas of the world who are attacking everything with vigor. Ultrasound is life. So be a Danny Rojas. Be excited about every visit. Even the bread and butter things like arthritis and anterior knee pain can present multiple approaches and learning opportunities. I was just talking with Dr. Cruz before we started here, and I'm very fortunate to come in a position where there's been some really incredible resources already put out on the YouTube channel. So be sure to check those out. I'm looking at the anterior knee protocols with Dr. Rao and Dr. Dixon, and then some complimentary national fellow lectures. So make sure, if you're interested in going on that anterior knee deep dive with me, check out these lectures and you'll be well set. So one point I want to get across is the concept of using ultrasound as extension of your physical exam. Dr. Baylorutz in his rotator cuff fellows lecture gave this great mnemonic the IRS pesters students. So kind of stepwise, be logical, be repeatable with your physical exam, including inspection, range of motion, strength and sensation, palpation, special tests. Particularly with the anterior knee, I think there's a lot of value in functional testing, looking at balance and proprioception, excursion of the knee, things like the single leg balance and Y balance tests. This paper here is a couple years ago, 130 some military recruits that were healthy time evaluation, Y balance, a single leg squat, and those who developed, 14 of those developed anterior knee pain symptoms, and they had a significantly higher excursion of valgus movement on their single leg squat and asymmetry in their Y balance test. So even in those who are healthy or symptomatic, even these simple tests can give you a lot of information. But then you're taking that physical exam and then using your ultrasound to kind of extend it, get a more detailed look, developing your hypothesis, and then using that to kind of fine tune your protocols as you move forward. And obviously ultrasound is going to be a powerful tool that you develop. Also being able to use dynamic ultrasound evaluations can take to the next level in your exam and as a clinician. Kind of setting the tone for opportunities that'll be very common for you and offering an opportunity to expand your skill set. Like I said earlier with anterior knee pain, it's kind of easy to get in this algorithm of, oh, it's another arthritis patient, this is what I do. But even in somebody who has, clearly radiographic evidence of osteoarthritis, this is a nice paper of 100 patients that were looked at. And with significant correlation between the number of ultrasound findings and decreases in pain and function. So the most common of that was knee effusion, but also things like quad tendinopathy, patellar tendinopathy, pes sensory bursitis, IT band issues. So the more ultrasound findings in patients with known osteoarthritis, the more likely they'll have worse pain and worse function. So never miss an opportunity to do an ultrasound exam and help your patient beyond what your standard algorithm might be coming in. Talking a little bit more about, we're going to go through a protocol. If we know they hurt in one spot, why would we bother moving the probe around, looking at all these extra structures as well, particularly the anterior knee. We don't need to get too much of a philosophical discussion about this concept of tensegrity, but You can see here all the different structures coming off of the patella, and those tendons, retinaculi, are all pulling that patella in different directions. So there's kind of this constant tug of war going on with the balance and alignment. So even though, in these lectures, oftentimes we have the spoiler alert of, yes, today the pathology is going to be in the quad tendon. We're going to go through how we diligently look at all these structures and see how all these different force variables might be playing into the patient's pain and function. This was a paper that I just saw that I think is going to, in prepping for this presentation, that probably is going to influence moving forward when I pull out the ultrasound and throw it on a young patient with anterior knee pain or concern of just like patellofemoral disorder. So these patients were diagnosed with patellar maltracking based on their the patella alignment on MRI. And compared to the controls with good alignment and function, those maltracking were 2 to 2.5 times more likely to have evidence of quadriceps tendinosis. And then looking at by quad versus patella tendon, that was pretty similar negligible rates for those under 20. But as soon as you get into your 20s, if they have evidence of maltracking, it goes from almost 0% of those will have 5% or so evidence of quad tendinosis, but 20 to 40, there's a significant, almost doubled or quadrupled rate of people having issues with the quad tendon that may be beyond what you would consider in patients who you might otherwise just diagnose with patellofemoral syndrome. Similarly, in the patellar tendinosis group, even those under 20, if they had maltracking, were significantly more likely to have findings in the patella tendon. So I say that as an example of using the ultrasound to extend your physical exam and identify areas of pathology that might be significant. Lastly here, shout out to our research folks at Spark. They have been doing this trial investigation, essentially where they're doing a patellofemoral grind test on these young female athletes with anterior knee pain. High level takeaway here is that those with increased discomfort with that grind test, indicating patellofemoral pathology, they had this increased signal in the posterior cerebellum. So there's the same pathways that are guiding our function and balance. So very preliminary pilot data here, but those kind of working concept there is that increased anterior knee patellofemoral pain may have an influence on motor function and other injury risk moving forward. All right, so before I get into too much trouble for going on my tangent, I'm going to dive back into the knee protocol. This is largely based on that curriculum document. These being the kind of expectations of a fellow by the time they reach the end of the year, being able to identify these main structures, kind of have this extra bonus structure of the infrapatellar branches of the saphenous nerve, and then a couple other structures that I kind of keep in mind based on my physical exam and kind of overall evaluation of the patient. Might look at that medial patellofemoral joint with a different angle, and then IT band, Gerdy's tubercle being more anterior than you might expect. Same with the pes sensorine. So why is protocol important? It's just like any skill, you got to wax on, wax off, be diligent, work through it, but you're going to develop a systematic approach. Get in the habit early in your training. A big benefit of the protocol is kind of forcing yourself to work through and scan normal structures rather than just going to an area where it hurts or you suspect pathology based on other imaging. So scanning more normal structures is going to build your library and build your confidence. When in doubt, make sure you compare to the other side. Protocol is also going to help your standardization, your communication, make it more repeatable and reliable as you build your skill set. And also just a word of encouragement to ask questions early. Don't be afraid to kind of point to the screen and ask for clarification if you're unclear. The sooner you ask those questions, the more confident you'll get early on. Also, build those skills and habits of optimizing your image as an early habit, so then you're not playing catch up as you're wrapping up the year. So into our case presentation here. I thought it was an interesting presentation because this guy is kind of presenting complaint over the last couple of years. He floated around different clinics, was they was having this left quad atrophy and some pain, progressively worse the last 2 years. Within our system, before coming to us, he had seen spine folks because of this atrophy, had essentially normal MRIs of the lumbar and thoracic spine, ended up getting referred because of the atrophy for a nerve conduction study, an EMG that showed some kind of negligible slowing across the fibular head and was essentially normal. They ended up referring him to neurology, but then he also came into us in sports medicine clinic. So he recalled an abnormal EMRI in 2013. He had some pictures of some old x-rays on his phone that showed a bifid patella, but otherwise were unremarkable. So specifically his anterior knee pain been worsening over the past year. He'd done some physical therapy without relief, done some bracing without relief. His pain was worse with prolonged sitting, going up and down stairs. He felt unstable, but didn't have any clear mechanical symptoms of locking or giving way. Excuse me. Physical exam-wise, as we mentioned, he had severe atrophy throughout his quad and VMO. Range of motion was within normal limits with normal sensation. Strength, he had some weakness and pain limitation in his hip flexion and knee extension. There was some tenderness through the distal quad tendon, as well as in the lateral patellar facets. His special tests, he was ligament stable. Thessaly, as you kind of fine tune how you do that test, some patients might report some pain, but I think it's important to distinguish where they're feeling that pain. Is there any mechanical symptom, and is that their kind of typical pain? So oftentimes patellofemoral quad patella tendon issues, they'll have some discomfort coming into that knee flexion moment with the single leg squat, but not necessarily be aggravated by the rotation. And even with the rotation, sometimes they can get some discomfort, but really distinguishing that between like the meniscal joint line type pain is important to not misinterpret that test. And then anyways, talked about in functional screen, this gentleman had that increased valgus moment instability in his single leg squat. Like I said, he came in with x-rays on his phone that took a peek at, so we don't have copies of those images, but just kind of reinforcing. I personally do like to have 4 views of a knee patient when I'm doing my initial evaluation. You may or may not have an MRI, but points been made in many of these lectures. It's important to review previous imaging, as that's going to be complementary to your ultrasound evaluation. So if you're transitioning from an environment where it was more primary care, they may have not always done weight-bearing views, but always make sure you're getting weight-bearing views. The AP, the PA Rosenberg, lateral and sunrise are kind of standard protocol. The reason you get that PA view is you come into flexion, look from back to front. You can see here in this A image is the same patient. So that's them there, and then coming in knee flexion, you can see how much that lateral joint space collapses there. So I think that's valuable information if that's not a view that you've are used to looking at. Getting into our patient positioning here, kind of standard is to get 15 to 30 degrees of flexion. This is a nice image of why that's important. So if you have them straight, this quad tendon is going to sag, but you can get the roll up there, put some tension on that tendon. That'll allow you to get your transducer more perpendicular to those quadriceps fibers and get a nicer view there. When we're talking about the extensor mechanism here, we're going to be talking about this quad tendon coming up and over Patella, and then you can see how those fibers are contiguous coming into the patellar tendon and inserting on the tibial tubercle. All right, so getting into our step-by-step on our protocol here. The first thing I'll do, whether it's for a focus scan or diagnostic scan, usually if it's a patient I'm trying to augment my exam with in clinic, the biggest question I have is this a real effusion I'm appreciating, or is it just kind of some soft tissue swelling? So I'll usually start by looking at the suprapatellar recess, get a sense if there's an effusion in there. You can see the alignment in these images as we move forward with probe positioning, but tried to label some images for you guys just because it was one of my biggest challenges being a visual learner, is making sure I clearly understand what's going on. But you have your patella here to the left, femur down below. Kind of nice to get that good view of the femur, make sure you understand the whole depth of this area. You have your suprapatellar fat pad up in this region. The prefemoral fat pad is that structure down there, and then that suprapatellar recess is sitting in here. This does demonstrate a little bit of fluid collection in there. This is not necessarily our patient currently, but just getting the lay of the land, going through our protocol. And then Dr. Cruz made this point in one of his recent lectures, but typically from there, my preference would be to work proximal to distal, just to kind of keep organized and have a standard approach, but we'll stay with the quad tendon evaluation for the end of the lecture for the sake of today's talk. So here we're scanning down, look at the patella tendon, tibial tubercle. Again, just kind of sliding that transducer down, make sure we're catching some of the patella. This individual was just tall enough that I couldn't quite capture both the origin and insertion of the patellar tendon. So we were kind of, after doing the panoramic view, scanning back and forth, but you can see the nice fibular echo texture, no clear thickening, no irregularity. I don't see any calcifications in there. So looking at those structures, there's patella, there's the tendon coming through, and then this is all Hoffa's fat pad in there. So, again, if you're kind of used to doing those anterior knee injections and might be learning a new superior lateral approach, this is one of those reasons why those anterior injections can be a little more just uncomfortable, is because you're going to be going right through that fat pad. And then, of course, getting used to looking in both orthogonal planes, long axis and short axis. So we're going to turn that patellar tendon, see that in short axis. Again, those are those more hyperechoic fibers overlying the fat pad there. Just have still images today, but you'd be scanning back and forth, both in short and long axis. It can also be helpful to throw in your color Doppler, get a sense if there's any chronic changes, neovascularization going on. So then we'll continue to slide down distally, see this insertion of the patellar tendon on the tibial tubercle. Again, got a nice fibular pattern. If you're being critical, you can kind of try and clean up some of that hypoechoic change, make sure it fills in. But again, got the tibia here, the patellar tendon coming in, and Hoffa's fat pad really just takes up all of that anterior knee. So to be aware there. And also Dr. Dixon's lecture goes into great, awesome detail about this, but you have your superficial infrapatellar bursa that would be in this potential space down here. And then her lecture gave a nice description of the case of a deep infrapatellar bursal issue. So being aware that those are there, there's potential areas of pathology, and also looking out for any cystic structures within the fat pad or any abnormalities you might see. And then again, just kind of flipping onto short axis here, catching that tibia. I kind of gave some, you can't see it great, but a little bit of extra gel standoff just to make sure we could catch the whole tendon. And again, you'd be kind of scanning back and forth, looking for any irregularity, thickening, hypoechoic change, evidence of a tear. And when in doubt, comparing to your contralateral side. Moving up to more of a kneecap evaluation, getting the patella in view here. Here we're trying to demonstrate the prepatellar bursa. So this whole big thick layer here is a gel standoff. Make sure I'm not crushing down the bursa. That would be kind of in this potential space here. Would see thickening that can be anechoic, mixed echogenicity, just depending on what those contents are. If they're infectious or just kind of a serious fluid collection. But then also recently saw a patient, look in this view, Like I said, we'll see irregularity at the poles, but you can also have really nice sensitivity using your ultrasound to detect bifid patella or more or an acute patellar fracture. Had one of those last week where was kind of equivocal on the X-ray, through the ultrasound on, and bam, there was a discontinuity in the cortex there, and we treated her for a patellar fracture. Moving to that medial side of the patella, catching that medial retinaculum and the MPFL. This structure here, I think is an example of why it's important to go back to your anatomy. And I think you throw your probe on, you're thinking, man, this just looks like a mess, and trying to clean it up and finding those fibers of the MPFL. And I think it's important to remember where those fibers are going to be attaching. So a lot of those are going to be coming down to the adductor tubercle. So you're want to make sure you're up here and angled towards that aspect of the femur. Getting that view here. The shadowing here is just some cartilage stripe there. And of course, you have your femur on that other aspect. This is part of the evaluation that Dr. Mountainer turned me on to. Doesn't quite do it justice in this cartoon here, but essentially I'm pressuring up, tilting the kneecap like it would if I was palpating the facets, and then just getting my probe up in there, similar to like we'll see in the trochlear cartilage, but just getting appreciating that cartilage on the medial aspect of the patella there, just looking for any irregularities, spurs, any strange cysts or anything that might be in the area. Again, just a cartoon there demonstrating that. And then sliding over to the other side, getting a good look at the lateral retinaculum. Same thing, a big fibrous structure holding that kneecap down in place. I guess kind of going back to that medial side, that's where most of your injuries will be on that medial retinaculum with your patellar dislocations. High up to 80-90% of people with a first-time dislocation can have damage to that medial retinaculum. But as we looked previously in that image, all these structures are intimately related and sharing forces. So important to slide over the other side and check out the lateral retinaculum as well. Kind of these same strokes, however, it makes most sense to you, but just also the updated curriculum makes a point of checking the medial meniscus and lateral meniscus. So, for particular focus for the anterior pro, getting the anterior horn, but I still think it's going to be most convenient for me to find that kind of on the joint line, and then kind of dynamically scanning back and forth, making sure a good picture of the medial meniscus, looking for any parameniscal cysts that might pop out, any extrusion or irregularity that you might see. More of a limited evaluation, but also a good habit to get into as you're moving forward and getting complete protocols. Same thing over the lateral side of the knee, checking out that lateral meniscus, and then scanning kind of circumferentially around the joint line to appreciate any pathologies there. Coming up into the trochlear cartilage, I should mention for some of those lateral structures, you'll get a good sense of on your positioning. Some people might prefer to kind of keep them at 30-degree flexion. Some people might for the lateral structures just because they're going to be more kind of linear in nature, going to a full extension in the knee so they can more easily track them there. But for the trochlear cartilage, it's helpful to get up to 90 degrees flexion. Again, this doesn't quite do it justice, but imagine you kind of flexed up here and then bring your probe down, shooting down on this cartilage stripe. Very satisfying when you get that in view. Again, it's just a single static image, but make sure you go back and forth, capture all aspects of it. Any irregularity, you can kind of use a video feature to capture that. But it's a small area of the cartilage, but can provide some helpful information, especially when you're getting into patient education. All right, get into the what everybody's been waiting for, the quadriceps tendon here. So this is more just a kind of prep of the scene. It's not our pathology view here, but again, getting those nice fibular structure here. The important point here is getting used to appreciating this kind of trilaminar appearance of the quad tendon. So as those tendons or the muscles of the quad taper down, become tendon, they're going to kind of insert in layers. So as we'll see in the cross-sectional image, that top layer is going to be rectus femoris, then the vastus medialis and lateralis kind of wrap in from the sides, and then the vastus intermedius makes up that bottom layer there as they come in and insert into the patella. So in our patient, first looking at the right side, it was pretty similar to the other image, right? It got good, fibular ecotexture, no areas of irregularity, maybe a little bit of cortical irregularity coming onto the patella, but within normal limits, and certainly is not symptomatic on this side. But then we compare that to his other side, and in these inferior and intermediate fibers here, just see obviously pronounced thickening, loss of that fibular ecotexture. It's hypoechoic to mixed echogeneity through here. You're also seeing some of these hyperechoic kind of punctate lesions, and that seems to be generating some degree of shadowing, limiting our view of the deeper recess of the knee. You can also appreciate some fluid coming up through that suprapatellar recess as well. But again, like I said, limited by shadowing there. Looking at the bony structure, have some osteophyte development, cortical irregularity as we're inserting onto the patella. So just kind of going back and forth, normal, abnormal there. Then we turn short axis, again, just see this very significant disruption in the quad tendon fibers, hypoechoic changes. In this view, you can't appreciate some of those calcification changes quite as much, but just kind of appreciating that in two planes there. Looking at quad anatomy again, like I said, we can see here how that rectus femoris would come over from the superficial layer, then the medialis lateralis coming intermediate layer, and then intermedius deep to that. Also getting the habit of scanning up proximally to the tendon, or if you're starting proximal, then moving distal, whatever seems to make most sense to you, keeps you in an ordered fashion. But here we'll see, make sure you're getting that bony femur view in there, so you're at an appropriate depth. That rectus femoris here is just kind of myotendinous junction starting to taper down. VMO medial on the left, vas lateralis on the right, and the intermedius down there. So again, I apologize, I wasn't able to get the videos functioning, but you can, as you practice, get used to scanning and seeing these muscles come down and forming that quad tendon. Here's our patient again. We made a physical note of his atrophy, just kind of comparing that side to side, an easy thing to use the split view, go side to side. So you can see on that healthy side, we captured this medialis view first. So the depth was standardized to the pathologic side, but that muscle bulk extends past the field of view there, where it's much less extensive on the pathologic side. Additional views that you can get are kind of wrapping around the VMO and lateralis as they kind of turn the corner and become contiguous with the retinaculum. So that's a piece of the curriculum to consider and get used to looking at. Same thing there on the lateral aspect. So just a couple bonus pathology slides. Here's a picture curve of Dr. Berrigan from his ongoing elastography study, but a really nice prominent calcification within that tendon as it comes down and inserts on the patella. Here he's thrown on the Doppler flow. We don't see any signal in that area, so another thing to check out there. In instances where you might have more acute injury or tear, you're going to see anechoic fluid collection, some retraction of the tendon coming through there. and also making sure that you have good views of your bony landmarks to make sure that you have a reference. And as we said previously, comparing the contralateral side if in case of more subtle pathology. Again, some other images, just kind of looking at other chronic changes you might see. Here's examples of thickening, and then a nice example of using that Doppler flow. So normal, symptomatic side, thickening, got some neovascularization happening there. So just as you're expanding your tool set, get comfortable with your machine and throwing these different tools on. Other bonus structure, the saphenous nerve. So coming up into the adductor canal here, you'll have, as you go down different branches, the infrapatellar branch is going to come off and then work its way down there. So for any like intervention or diagnostically, you want to make sure you're catching it before it branches off. So you're tracking down into this view here where you have your sartorius, VMO, and then your adductor complex. Your kind of home base landmark with any nerve is to find the vasculature. So femoral artery and vein there. And then this saphenous nerve is starting to come off here. And then scan that as you see the very subtle shadowing of the infrapatellar branch coming off. Again, just a kind of descriptor of that. So you want to kind of make sure you're scanning here, seeing where that branch comes off, doing any blocks or anything, you only proximal to that branch in the case of anterior knee pain. And then here's just another cartoon graphic, if that makes more sense to your brain as you're getting used to look at these images. So you can see the nerve sitting in there, just like we have in the structure here. And again, some of my bonus structures I might take a look at are the distal IT band, Gerdy's tubercle. Those are both going to kind of be more anterior, looking for any bursal fluid collection. Some of this is going to be based on physical exam. Similarly, might consider scanning over on the medial side, looking at the pes anserine as well. So getting into our ultrasound report, respecting every time, wrapping up here. Our reports tend to be more kind of complaint focused, with more description of pathology and just kind of summary of the normal structures. But said the extensor mechanism demonstrates normal thickness and ecotexture of the patellar tendon. However, the insertion of the patellar tendon on the tibial tuberosity is normal in appearance. Superior pole of the patella demonstrates mild cortical irregularity. There's severe undersurface tendinopathic change in the undersurface of the quadriceps tendon with associated hypogeneity, thickening, and loss of fibular ecotexture in both short and long axis. Small punctate hyperechoic foci scattered, consistent with calcific deposits. The typo there, fibular pattern is only appreciated in the superficial fibers of the quadriceps tendon. No full thickness tear of the quadriceps tendon is appreciated. There's associated significant atrophy of vastus medialis muscle bulk in comparison with the contralateral right side. And then including just kind of a clinical summary statement there at the bottom. This is consistent with the chronic partial tear / tendinopathy of the undersurface and mid-portion tendons. So this wrapping up here, this is a gentleman ultimately ended up going for a vacuum assisted debridement procedure and tenotomy. We did have the opportunity to rescan him at 4 months with some improvement. So here's his previous images, and you can see afterwards that there's some improvement in the structure. Excuse me, a little bit of filling in here. And then he's actually going to be coming in the next couple of weeks. He underwent an additional course of some shockwave. So it's a long-standing chronic issue, and he's still working through it, but we're trying to make progress. Some references there, and then just thank you to my family and my co-fellows, and yeah, we look forward to hear any additional feedback from Dr. Cruz and whoever else might be still on the call.
All right. So great job, Charles. That was really well done. It was very comprehensive, and you did a nice job going over all those different structures. I think the point there is that, or one point to make is that everybody thinks anterior knee pain is either patellofemoral pain or patellar tendinosis and nothing else. But there's really quite a large number of structures in that area that deserve evaluation. So always keeping your differential broad, like you mentioned, is important. From a protocol standpoint, we say this all the time, and you hit on this, and I just want to say it again, the importance of the protocol can't be understated. It's very easy to clinically, you think somebody has whatever diagnosis, quadriceps tendinosis, and then you just use your transducer, take a look at that tendon, and you can miss something else very easily. And so having your protocol, making sure you go through, the specific structures within that protocol, but then obviously altering it based on the clinical question is important. So you said that, and I just wanted to highlight that because that was a really good point to make. My protocol is similar to yours. So for this, I like to start over quad tendon and then work caudally. I do tend to sneak over medially in most of these patients. I think, taking a look at MPFL, medial joint line. At the medial joint line, you can look at meniscus, MCL, and look for effusion or other signs of intra-articular pathology. So I really don't have much to add on that. I think our protocols are fairly similar there. The only other point I think that I have is understanding, some of the nuances with the anatomy here. So with the quad tendon in particular, we know it's a trilaminar tendon, right? So the superficial aspect is the rectus component. The middle consists of the vastus intermedius and lateralis, and then the intermedius forms the deep portion. And we can certainly quite often see preferential involvement of different layers, right? And I think with your tendon, your picture actually was great. It looks like, there's relative sparing of the rectus component. The superficial third was probably the least affected. And then certainly your middle third and deep third are where most of the money is at there. So we will often see this and often see preferential involvement of different layers. So that's a good picture. That's a good case, and just something to point out there. I think, you covered most everything, Charles. So I really don't have all that much else to add. One just random esoteric point to make. One thing that we think about, if somebody has, anterolateral pain, there is this tensor, the vastus intermedius, which can predispose or can cause some anterolateral knee pain. So just something to keep in mind there. But other than that, I think that's it. Doug is not on today. I don't know, Brennan, if you have anything, you can certainly yell. Otherwise, if anybody else has any points that they'd like to make or any questions, we'll give 6 seconds and then we will close it. Going, gone. All right, that's good. I mean, that means you covered everything. You did a really good job. So appreciate it, Charles. Yep, thank you. So we are somewhat back on schedule now. Like I mentioned previously, Charles did an excellent job closing up the fellows portion, this current fellows portion, which again, our fellows are just so exceptional. They always do. Every single fellow that presents does a great job. And so as expected, this quote unquote season of our fellows presentations was excellent. So off next week, back on the 5th of August. Chris Visco is going to join us, and he's going to give a talk on a pectoralis major tendon injury. So again, that'll be Friday the 5th, I believe. So, all right, happy Friday. Stay safe, stay cool, and we'll see you guys in a couple weeks.
All right, thank you all. Thank you, Dr. Cruz.
Yep, thank you.